Well, hey everyone, welcome back to the BrokerLink podcast. I'm here in the studio with Josh Slattery, our Executive Vice President, and we're doing a deep dive into the final rule of 2026. Some of the takeaways you've gotten from some carrier rollouts you've already attended, and also talking about member retention as we go into the upcoming AEP. So Josh, thanks for joining us. You want to just get right into it?
Yeah, let's jump right in. Thanks for having me.
Cool.
Yeah, I think one thing that, a lot of folks have kind of come to us and asked about was just the final rule. Obviously, this time last year, we were certainly dealing with a final rule that had some significant implications to our business. This year, not so much. That's the good news. So the proposed rule comes out generally, late fall, and then we have some time to respond to CMS and sort of influence some of those changes, and then you have the final rule that comes out. Generally, we see that in April. If it's delayed, maybe May. But this year when it came out, there were only a couple provisions that really impacted us as agents and distributors. And a few things that we anticipated from the proposed rule that luckily did not make it. So let's start with a few things that didn't make it. One was the expansion of GLP-1 coverage for obesity. So that's your Ozempics, Mounjaros, right? Those drugs that are currently not in the Medicare formulary. And in fact, for obesity specifically, of course, for diabetes, they can be prescribed. But there was a proposal in the proposed rule to expand those for weight loss drugs for, obesity. Weight loss drugs are currently excluded from the Medicare formulary, and that did not get approved. So that would have, that would have allegedly increased cost and caused some more burden on the Medicare system. It's already financially pressured, right? So I think that's a win for the health plans. The second was some rules around debit cards. We know that the debit cards have become very popular, specifically around the food card benefit, and there were some concerns, I think, for some that food card was being used as clickbait and, used to kind of misrepresent a plan's benefits, get people in and then bait and switch onto another benefit, right? And we've seen a lot of that with some of the leads that are being generated from call centers and these direct transfers and things like that. So the rules were that there needed to be increased transparency and most importantly, that you couldn't use that debit card, food card benefit as a marketing tactic to generate leads. And so that did not get passed. And we suspect there'll be future rules around the debit cards. There's still some concerns there, but for this year, it's off the table.
When you say it didn't get passed, what are the implications of that? Just nothing changes, basically?
Nothing changes.
Okay.
It was in the proposed rule, didn't make it to the final rule, so it's not something the plans are going to have to react to at this time. However, just it being in the proposed rule is enough for plans to say, okay, this could come up later.
Yeah.
In fact, let's maybe go ahead and start to make some changes to any of the proposed rules that don't make it into the final rule to prevent CMS having to address it. Let the plans address it. And that's generally the better tactic to remedy those situations. The third thing that didn't make it, and definitely this was the most concerning, was the changes in marketing rules. So there was a proposed rule to require all communications, not just lead generating communications, but everything from educational materials to business cards to websites to any sort of generic communication that would have to then go through HPMS, which is CMS's approval for marketing materials. And that would have created a lot of bottlenecking going into HPMS leading into AEP, because we would have had to submit all of our materials that never had to go through that process before.
Right.
And even looking at what's happening within CMS right now, you've seen DOGE come in and reduce the workforce. Right. So in order to take on a new regulation like this, you'd need a lot more people at CMS.
Yeah. How would you even enforce that?
Yeah.
It's like a crazy undertaking.
A huge undertaking. Yeah. And so we can all rest easy that didn't make it through. And so that's an important thing to note. Again, I think that's the most significant out there. The two things that did make it through that are worth discussing is there was some SSBCI qualification changes. And so the SSBCI, for those that don't know, is the Special Supplemental Benefits for the Chronically Ill. Mm-hmm. We don't want to go too far into this topic here today, but the VBID, the value-based insurance design, allowed plans to file benefits based on income. And so this pertained mostly to that DSNP market where they could give items like the food card and rental assistance, gas at the pump, $0 drugs, without having to go through an approval process. It was just if they're dual eligible, they qualified. This year, that goes away. SSBCI is going to be the method now for plans to approve these benefits, which means somebody that's eligible has to have one of the chronic illnesses defined by the plan. Each plan is handling SSBCI slightly differently. As we move into AEP, that's something we'll definitely address in our kickoff events and future podcasts. Where what is the new lay of the land with SSBCI? Is there an attestation that's required? Is there our plans looking at prior claims? Is there an interview, kind of like a health risk assessment that the member has to go through? But there were some changes specifically to SSBCI, and that was around the eligibility criteria. So in the past, it could just be an attestation. Now it can't. Now it actually has to be, if they attest to it, it has to be approved and verified either through prior claims or through a provider. So it's going to make that SSBCI qualifying process more difficult than it was in the past. Yeah. At the same time, that VBID's going away. So the timing wasn't exactly favorable for the plans for these rules to come into effect. There's also some non-allowable items that you wouldn't even think would be allowed, but like alcohol, tobacco, non-healthy foods. So clearly the purpose of the food card is that they can go in and get healthy foods and foods that are going to create a better, medical path forward for that member.
So I want to make sure I heard you correctly. Whereas in the past, qualification for this was income or condition, now it's just condition.
Correct.
Okay.
Yeah.
It's a big thing to note. I mean, a lot of times those things can both be true at the same time, of course.
Yep.
But that's something agents should know is you might have had some clients on a DSNP that it was just purely based on income, and so they had all these extra benefits.
Yep.
Yeah.
Yeah, and so for this year, as an agent, and you're sitting in front of somebody talking about a dual program, a DSNP program, you're going to have to explain to them that it's not guaranteed for everyone. And some plans are already quoting, 90-95% of dual eligibles will qualify via SSBCI.
Yeah.
But it makes it a little bit more challenging for the agent. Mm-hmm. It also could lead to a poor member experience because you have agents saying, you're going to get this food card. Yeah. Turns out they don't.
Yeah. So for the, and you said there's still more to be discussed in future episodes, but as of right now, we don't even quite know what the qualification intake is going to look like yet.
We don't know.
Because it's basically saying like, in order to even enroll in the first place, you're going to have some verification that you qualify.
And some plans could include things like hypertension. They could decide that they could file the plan based on certain chronic conditions that open up those benefits. And so one plan may allow hypertension, one may not, right? So it's going to be based on that criteria that the plan defines that are within the CMS guidelines, of course.
Yeah.
But every carrier could handle this SSBCI process slightly differently, and that's going to add more complexity to the agent and how they present these plans to the potential member that they're talking to.
Okay.
Lastly, lastly on the final rule, I'd say there was some risk adjustment changes that were cemented from 2024. And this is really to remedy Part D, kind of level the playing field between Medicare Advantage and Part D. And it was really just a portion of the MA funding for MAPD plans, those that include prescription drug plans, now has to move into the Part D component. So there's this is to try to stabilize, the standalone Part D market, and say plans that have MAPDs have to have some funding that shifts over to standalone Part D. And this is to try to mitigate some of these rising premiums on the standalone Part D side. So it's just to kind of level that playing field between those two product lines.
Okay.
So nothing too big there. Again, final rule wasn't significant this year other than a couple of changes. One thing to note, I think, is that this proposed rule that we see for 2027 later this year will start to give us more insight into how the current administration is viewing some of the prior administration's changes. Will they come out with, a lot of changes in this proposed rule, or will they do what we kind of expected, which is be more favorable to agent distribution? So we're all waiting to see, anxiously waiting to see what this proposed rule looks like this coming year.
Cool. So that's the rule.
That's the final rule. Now, the other thing that's happened recently is, we've had the one big, beautiful bill, right? And I think there's a lot of questions about how does that impact Medicare.
Yep.
And I'll go through this in some detail here, but really there's not a large impact to Medicare. Some significant changes to Medicaid.
Right.
And, just to kind of underscore all this, right? We know that now MA is up to about 53% penetration. So it's the most dominant plan choice from Medicare beneficiaries. This current year, we've seen some things that really haven't happened in the past, and that's that 6% of enrollees in MA plans that had drug coverage this year were experienced termination. So their plan went completely away. That's unprecedented. We haven't seen that kind of volatility in the past. And as we saw, a lot of shopping that generated. And I think that this AEP will look very similar. I think we'll see similar amounts of plan terminations. This was the first time that we saw less MA plans than the prior year. So there were fewer MA plans in 2025 than there were in 2024. And in previous years, we've just seen pretty much increases extending back to when the ACA got introduced, 2014, 15, 16, we did see some decreases. So it hasn't happened in about a decade. We've also seen, higher drug deductibles, higher MOOPs, right? A lot of increase in costs for Medicare beneficiaries, where for the past several years, it's just been beneficiaries accustomed to improved benefits, lower costs every year. They just expected to get their ANOC and their plan gets better. Now, for the first time this year, it got worse. And I suspect from what I'm hearing, that's going to be the case for this year as well. Obviously, plans pick and choose kind of where they want to invest. So some markets, like Dallas, Fort Worth as an example, there may be carriers here. They're very dominant. They still continue to keep stable product here. Other carriers, right, may make changes and divest in this market. So it's going to be kind of this plan, targeting of where they can win, where they can't win. Likely they start to divest.
Okay.
The other thing is that, we've seen more changes in regulatory policy, more reform since the inception of Part D. So we're going through a lot of changes regulatory-wise, and that, of course, has a lot of implications in the market and generates a lot of volatility. So what have we seen as a result of that, right? We've seen plans either exit markets or, change benefits, change network design. Plans are having to react to these market conditions. A couple things too, just to note that the IRA is here to stay, right? There's no clear movement from the Trump administration that they're trying to quickly fix the IRA, right? We know that this major shift of liability from the government to the plans has had serious consequences, but we don't really see anything in the immediate future that's going to remedy that. It's here to stay, and the plans are going to have to figure out how to make that work.
And specifically, we're referring to the $2,000 drug. Yeah.
Yeah, the $2,000
and then the
max
ability for them to split it into monthly payments.
You got it. The MP3 copay smoothing.
Yep.
Although that hasn't really been super popular, there doesn't seem to be any, current legislation or regulatory activity to impact that.
Okay.
Okay, so the big, beautiful bill. What's in it? A lot impacted the Medicaid market, eligibility limits and work requirements. And really, these are designed to limit enrollment into Medicaid. Let's be clear. The administration's goal here is to try to prevent as many people to get into Medicaid. It's a cost cut mechanism. And so these work requirements require somebody between the ages of 19 and 64, so it doesn't affect that Medicare population, to work 80 hours a month or some sort of community service.
When I first read that, because I was reviewing this morning, I saw the 80. I thought it said 80 hours a week.
Oh, yeah.
At first I was like, well, no one's going to be on Medicaid.
Yeah, nobody qualifies.
80 hours a month. Okay, that's a part-time job.
Exactly.
Yeah.
And there are some exemptions, women that are pregnant, parents that have young children, somebody with
certain disabilities.
Exactly. Serious medical conditions, et cetera. The other thing to point to is state funding restrictions. So they've put in these abilities for states to capture more funding if they close some federal gaps, right? So basically it's the administration saying, hey, if the states help us here, we'll open up more dollars for Medicaid in the state. So there's some just state funding restrictions, some cost sharing requirements as well. Anybody from 100% to 135% or 138% of the federal poverty level is required to pay like a $35 copay for some services, up to 15% of their income. So there is some cost sharing that's been put in. And then lastly, not too significant on the Medicaid side, is a rural fund. Again, it's just money that's being put into the states to help improve healthcare in the rural markets, which we know are underserved and typically don't have the same quality of care. The SEP is another thing that we want to talk about on the ACA side that was impactful, changing from November 1st to December 15th, and no more SEP for income.
Right.
So again, these are measures on the ACA side to limit the enrollment. There's also exchange verification and auto re-enrollment changes. So the requirement for pre-enrollment verification of eligibility for premium tax credits, right? So now you have to verify income, immigration status, eligibility, all before these tax credits are issued. So that again could limit folks' eligibility to get those tax credits, therefore limiting the enrollment.
This one makes sense. I mean, we've heard stories of fraudulent agents that sign someone up and they claim X income, X this, and then 3 months later they just sign them up again because of the SEP loophole.
Yeah,
they've never verified anything. So there's people that have been getting $0 a month silver CSR plan, the best plan you can get.
Yeah.
For $0 a month.
Right.
And everything's just a lie.
Yeah.
And then the agent's collecting their commission. That's problematic.
It's healthy change.
Yeah. That's good.
And it affects the re-enrollment. So where they could just be automatically re-enrolled, again, those things have to be
right.
It
makes sense. We have to file our taxes every year. You should probably, if you're getting a tax subsidized product, you'd have to re-enroll every year.
Yeah. So it makes sense, right? And then on the Medicare side, there's a few things to note. Not that really impacts agents at all, but important to know that physicians did get a 2.5% pay bump on their reimbursement rate. Physician community isn't too happy about this. They wanted a process for an increase in their funding as as time progresses, right? So it's like with these cost of living increases, that kind of program, they hoped that this would be an ongoing thing, what is just a one-time 2.5% increase, and then it's done.
And that's on the fee-for-service?
Yeah, that's on the fee-for-service side. The other thing is non-citizen eligibility restrictions. So it excludes like refugees and people that are here on asylum. So just a kind of a small segment of those that are no longer going to be eligible for Medicare. And then there was an orphan drug exemption, which pertains to the negotiations within Part D. Basically, in the IRA, it stated that if a drug was only treating one rare disease, it wasn't eligible for negotiation under the Medicare negotiation program. They've adjusted that to include one or more rare diseases. So a drug could theoretically kind of treat multiple or a couple or more, rare diseases, and then that would be excluded from Medicare to be able to negotiate that drug.
Okay.
So not a whole lot to write home about, in terms of the one big bill. I kind of had to fish for some things, to really talk through about Medicare. But what wasn't in the bill is more significant. So what wasn't in the bill? There's no cuts to MA. This took intense lobbying efforts because there's a huge push to cut MA. And we know that would have had some significant consequences on a program that's already in financial distress. There was no restrictions to prior authorizations. We know there's a lot of rhetoric right now around how prior authorizations are frowned upon by a lot of medical systems, hospital systems, consumers, of course. There was no PBM reforms, so Part D rebates were maintained. No restrictions on state AI regulation. So right now, there's a lot of talk about AI. There's going to likely be some kind of national reform to the framework for how AI is regulated. And that would prevent the states from having their own position on this. So I think in the meantime, we're going to see kind of rocky policy and interpretations around AI as each state sort of handles it a little differently. So in the future, I think we could see some sort of federal regulation around how AI is used, specifically in our world. And then no major changes to the IRA and drug pricing. The timing here was critical because this removed the threat of MA cuts for the short term, but we know that there's still going to be a lot of talk in the future about ways to improve MA, potentially cuts, and so we just have to be prepared for that in future bills, future regulatory activity.
Cuts. I mean, Dr. Oz is pro-MA, so there's that.
Yeah, and I think, and to that point, I think Dr. Oz is coming in with an open mind. He's been kind of under the radar quite a bit from a policy standpoint. He's very approachable from what we've been told. He's very receptive. Here's the difference with kind of that hierarchy right now. RFK is the first administrator of CMS to not really come from a regulatory background, right? Like people in the past either come from Medicare or Medicaid and been heavily entrenched in this space, so came in with a lot of their open positions, where RFK is allowing Dr. Oz and some of the folks underneath him to impact and influence policy, versus him being the one coming in with the ideas.
Right. His thing is just, I want everybody to be healthy.
Yeah, food,
how can
nutrition.
we figure out how to make people healthier?
Yeah. So in terms of, the legislative horizon as we look forward, we know that there's still a few things out there looming. One is the No Upcode Act, and that represents a major cut to MA. It prohibits the use of diagnoses derived from chart reviews and HRAs to adjust MA payments. So if this were to get passed, it's just a current proposal. It would be a big threat to MA. It would impact the way that they can upcode and receive funding on MA beneficiaries. It would have to be coming from actual patient results versus just some of these, charts and HRAs. There's a Guard Veterans Healthcare Act that's also out there. Right now, the VA doesn't bill Medicare, the VA being the Veterans Administration, doesn't bill Medicare for charges from those that are on Medicare. They have kind of two independent systems. And so this act would allow VA to bill Medicare for some of these services that are conducted. Right now, you can go enroll somebody to VA. They can still go to the VA hospital and get medications. They can still go have operations there. And then they can have a private doctor as well, so they kind of get the best of both worlds. And this would still allow them to do that. It doesn't threaten that, but it does allow the VA then to bill Medicare for some of those services that are rendered outside of their private doctor.
Okay.
Another thing is just some prior authorization reform. There's additional bills that are still live out there that are really trying to attack prior authorization. We've seen a lot of that in the news, just about the impact of prior authorization. So more to come on that.
Man, the tricky part on that topic is like, you've got to have it. Like, there has to be some guardrails.
Yeah, even
for billing. I mean,
even original Medicare just announced they're going to have prior authorizations.
Yeah, like I understand the argument. Like if you talk to especially nurses, they're like the number one voice of why this is evil, that there's these prior authorizations. It's like, you understand, like they only care about the patient and just want them to get from point A to B as quickly as possible.
Yeah.
They don't want any in the middle. But it's like, I get it, but there has to be some guardrails around it or it's going to get taken advantage of. That's just how, that's human nature. So it's like, how do we find the middle on this topic?
Yeah, I heard a presentation not too long ago where somebody noted it for a Medicare Advantage claim, it costs about $47 per claim to the provider. And with original Medicare, it was less than $1. So there's some operating costs there because of the coding and because of the documentation that it drives cost up. I think there's been some debate around, do you allow physicians that have accurate submissions, 95% or more of the time to just get instant approval, right? So there's not this delay, right? They just submit it, they get it approved, it goes through. But doctors that have a poor performance when it comes to these submissions, they're having to be sent back. They're submitted incorrectly. They've got, some kind of error in the code that was submitted, whatever the reason might be. Those have to go through a process and be approved by the carrier. Yep. But as the hospitals continue to get squeezed financially, they're looking at things like operating costs very closely. Yeah. And this is one thing where I think you have a debate on, is it too difficult of a process, or I'm spending all this time and everything's being approved, why can't you just let me go ahead and have instant approval when these requests come in?
And that turns into a technology conversation too.
Yeah.
How many of us, or how many of these systems are still just using super outdated methods? So the hope, fingers crossed, would be there is sort of a sweet spot with this. Yeah. It's like, there has to be some process. It can't just be unlimited, whatever you want, whenever you want.
Right.
But hopefully, I just hope the narrative people can start to understand, like, it's not just out of evil intentions or something, which is what is proclaimed out there. It seems like, it's more practical reasons. So
there's a compromise, a middle ground somewhere.
Yeah. And you said Original is starting to do their own prior auth stuff now.
Yep. Okay. They just introduced that they will start to have prior authorizations as well.
Okay. So for you agents, that's a talking point.
Yep.
Just to know, like, because a lot of times that's the MedSup pitch. And it still probably is somewhat, which is more flexibility.
Yep.
But it sounds like even Original is going to have a little more, some guardrails built in.
You may have to wait, instead of getting that MRI while you're at the hospital, or at the doctor's office, you're having to wait and come back, and that's kind of the inconvenient part, right?
Yeah.
Is that there's some delays. You're really wanting to get in to get this service done. And agents get those calls sometimes, right? my health plan's not approving it and the doctor's blaming them. So we'll see, like you said, maybe a little bit more of that on the original Medicare side, which will balance it out. And again, prior authorizations are common even on the group side, right? So this is not something that is uncommon even in the under 65 world.
Yeah.
So what are some of the implications of these changes? Obviously we already know that, there's some financial pressures out there. So carriers are having to make some tough decisions, right? Some got out of the business, like Cigna, sold to HCSC, right? Others are pulling out of certain markets and deciding, like Aetna decided, hey, we're going to get out of the ACA, right? You have certain Medicare Advantage carriers that have pulled out in previous years. So this year, I think we're going to see probably more plan terminations where carriers just, like I said before, aren't winning. And then, I think that, again, you've seen these last 5 to 7 years, this environment where it's all about expansion. We're moving into new states. We're moving into new counties. We're adding new benefits. Now it's going to be the opposite. We're pulling out of these counties. We're pulling out of these plans. We know PPOs are under threat, right? So are we divesting out of PPO and moving more into HMO? Are we seeing people move more into a med sup when they truly want flexibility because that PPO just doesn't offer the benefits that are as attractive anymore, or their plan was termed and now they have guaranteed issue into a med sup? And to further that conversation, we saw MedSup grow this year for the very first time in a while, right? And when I say MedSup, I really refer to original Medicare. Right. Original Medicare grew by a couple of 100,000 lives, where we've seen MA growing at the expense of original Medicare years and years, in the past. This year, Medicare Advantage still grew, didn't grow quite as much as it did in previous years. We've seen it start to slow down, but then we see, original Medicare starting to grow for the first time. So that's an important note, just to say what happened there. Likely there was a lot of plan terms and people went on to a MedSup because they had that guaranteed issue. Also, people turning 65, perhaps their doctor is saying, you know what, we don't maybe have the appetite for MA like we had before, and they're starting to drive more of a conversation around original Medicare in a Medicare supplement.
Yep.
So, early actions from the administration. We've seen, reductions in force across government agencies, including Health and Human Services. A lot of long-time standing people within these agencies have now left. And these were kind of the people that were getting the work done, right? So there's some deficiencies in these agencies as a result. And we're going to see, some continued restructuring and consolidation of these agencies, and policymakers are dealing, with a range of issues. So just that's something to note that, there's some significant changes because of some of these rifts and new people coming into these agencies. Health equity initiatives have been shut down. So we're seeing a movement by the administration deprioritizing health equity initiatives, focus more on health-related immigration policy. Make America healthy again, right? As you mentioned earlier, RFK, very focused on wellness, nutritional health, chronic disease prevention. And then there's interest in identifying targets for deregulation. In fact, there's been a lot of requests for information, RFIs as they call them, from CMS, just to understand, what regulations are really impactful, which are not, and they've put a 10-to-1 ratio on deregulation. So you must deregulate 10 regulations to add one new one. So there is certainly a movement by the current administration to deregulate, and if you are going to add in new regulation, well, we got to get rid of 10 to do that. Where in the past that was not the case. So this heightened focus too around identifying and eliminating fraud, waste, and abuse. Right, that's a very clear priority for the current administration. So as again, we can see this next proposed rule, what all will be unraveled there, what all will be the focus. It'll be very telling of what are the priorities of Dr. Oz, RFK, and the Trump administration as it relates to Medicare. And we suspect that, we've kind of seen this with Trump's style. We expect there to be a bold, proposed rule with a lot of detail in it to kind of rattle everybody, and then what ends up actually being passed will be something different, right? It'll get the conversation started, but we'll end up probably in a different place than what's proposed.
Yeah.
Just reading through some of my notes here too, AI and technology enablement, we kind of talked about that earlier, but there's some inside new CMS that thinks AI is a solution, right? It can potentially be a tool to help identify some of these wastes out there, right? How can technology reduce some of the waste and some of the abuse out there in the market? The other thing is, enhanced audit activity. There's been a lot of audits, specifically with like upcoding as an example, ways to claw back. If there's audits, they determine there was upcoding that was done incorrectly, then they can, claw back some of those dollars and start to have some consequences, of perhaps some, just some poor practices within the carriers.
So a lot of, if I'm understanding right, like a lot of the emergency room stuff, that kind of thing. Is that what you mean?
I think it's more of, how was a carrier upcoding members,
on the carrier side. Got
on
it.
the carrier side. So just auditing how, what was their justification for some of those upcodes, and when there wasn't, then they claw back those dollars.
Okay.
So plans sort of have to be responsible for prior decisions that were made, and that couldn't hurt them financially.
Gotcha.
So, and if they know that there's going to be increased audits, what did that drive? That drives them to be, more careful, right, as they do these upcodes, these prior authorizations, as they deal with the kind of mechanics behind the scenes. They want to be super careful so that they don't get audited and end up having to pay back some of those dollars that were billed to Medicare. So, I think that's a pretty good kind of just overview of what we've seen. The bottom line here is we are optimistic for a more stable regulatory environment moving into 2027. We do know that Dr. Oz is very supportive of MA. We know that he knows that MA is very popular, will remain popular, and that the overall prospect for the program is very strong. Despite rate cuts, policy changes, it's going to remain popular. And Medicare Advantage is here to stay, and so I think we have an administration that's just trying to cut some of the fraud, waste, and abuse out. But I think we're in a stable regulatory environment overall. Medicaid, however, will go through mass turbulence. Right, there's a lot of changes there. Fewer people will be eligible. That's certainly one priority of the administration. Duals could very well be impacted in our space just because less people will be eligible for Medicaid. Policymakers' scrutiny on costs and government spending will remain. I think that we'll see a lot of pressure, just given the pressures on the federal deficit. Cost cutting is going to continue to be a priority. More uncertainty certainly means more deliberate and focused market strategy for insurers. So it's no longer a guaranteed focus on growth at all costs. It's really how do the insurers make deliberate decisions on where to invest to where they can weather the storm and kind of get through some of these financial pressures, headwinds that they're facing. So more to come as we continue to go to these carrier rollouts and we start to kind of see the strategy. We'll come back with some more updates and, looking forward to our kickoff events too, where we can kind of hone in on a lot of these changes, hear from the carriers directly, bring a lot of our technology partners to the forefront. So just, looking forward to another disruptive, but also very productive AEP.
All right. Let's close with that.
Awesome.
Thanks.
Thanks again.